Welcome to our webinar, Ask the AML Expert. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generosity of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. If you should lose your connection during the webinar, you are able to continue to listen to the presentation using the call-in number in your reminder email. Our program today will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Our presentation today is meant to be an interactive webinar. Our presenter has some slides to start out the program, but the majority of the program will be a Q&A. Today's program is meant to answer all of your questions. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you've finished typing, just hit enter. We'll do our best to get to all questions today. When asking questions, I do ask you to do 2 things to help me manage them. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Salman Fazal. Dr. Fazal is a hematologist oncologist with West Penn Hospital in Pittsburgh, Pennsylvania. He specializes in treating patients with ALL, AML, CML, leukemia, and polycythemia. He attended King Edward Medical College, completed a residency at Griffin Hospital and Rosalind Franklin University of Medicine and Science, and a fellowship at Allegheny Health West Penn Hospital Medical Education Consortium internships, residencies, and fellowships. Dr. Fazal is board certified in internal medicine, medical oncology, internal medicine, and hematology. It's my extreme pleasure to welcome Dr. Fazal today.
Thank you. Let me share my slides. Can you see the slides now?
Yes, Dr. Fazal, thank you.
Thank you. Thank you for the invitation, and appreciate the opportunity to be able to discuss with all of you about acute myeloid leukemia. As Lee mentioned, we'll be discussing about acute myeloid leukemia. I'll go over through some of the key aspects and hopefully may be able to answer some of the questions from my presentation. And then, of course, we'll have an interactive question and answer session about acute myeloid leukemia. So I always like to remind myself about the inspiration that drives us to take care of leukemia patients. So I dedicate my presentation to my patients who inspire us to work hard every day for our patients. So I just dedicate my presentation to these patients. So start off with talking about leukemia. So we believe acute leukemia is blood cancer. And if you can see on the slide, is just a diagram of how blood formation occurs in the bone marrow. And it starts off at a very early stem cell level, and then it distinguishes into 2 types of cells, myeloid cells and lymphoid cells. So in acute myeloid leukemia, the cells that undergo malignant or cancer transformation is myeloid cell, as you can see over here. The blue box represents the cells that undergo malignant formation and become acute myeloid leukemia. If you look at the entire cases of acute myeloid leukemia, there's more prevalence with age, and most of the patients are in their late 60s. The average survival that we give for acute myeloid leukemia, and this is from SEER database, it's an old analysis. We fortunately hope that there's much improvement in survival, but it is about 5-year survival for all of the patients, including age above 70 and such, is somewhere around 26.9%. What causes acute myeloid leukemia? That's a very frequent question that we get. And on the right represents the most common cause for acute myeloid leukemia, and the answer is we do not know. We do know that age does put people at risk, and as you can see, median age is 67, so most of the patients are older. However, we know that less than 5% of patients, as you can see on the left, have a familial or genetic predisposition. There are syndromes that are associated with high risk of transformation to acute myeloid leukemia, such as GATA2. We have learned about RUNX1, and more recently, there is a mutation called DDX41, which has been associated with the transformation to or development of acute myeloid leukemia. So we have learned more and more about patients who have genetic predisposition. When it comes to known etiology of drugs, there is known etiologies in terms of development of acute myeloid leukemia. Chemotherapy and radiation has been notorious in terms of leading to development of acute myeloid leukemia. There are a class of drugs that has been associated with evolution to acute myeloid leukemia. Some of these drugs are listed here: topoisomerase 2 inhibitors and DNA alkylating agent. These agents are frequently used in treatment of breast cancer and also used in treatment of testicular cancer. So unfortunately, when patients are dealing with those cancer, they may not realize the low risk of causing acute leukemia from those agents. As you can see on the bottom is the peak incidence following the exposure of those agents varies between 1 to 3 years versus 5 to 7 years following the exposure. And as you can imagine, when they're dealing with those cancers, they're worried about that. And unfortunately, later in their life, they could be dealing with this consequence of chemotherapy. So how do we make the diagnosis? We do make the diagnosis by doing a bone marrow aspirate biopsy, and that's just to give you a diagram of how a bone marrow is performed. With the help of this special needle, we take out samples out of the bone marrow space, which you can see is the spongy area where we take out the samples. It is unfortunately an uncomfortable procedure. However, most of the people can deal with this procedure without sedation. However, in some people, it's because of their anatomy and the scar tissue, they may be experience a lot of pain. And for that reason, we sometimes use sedation and other alternative methods to get a good sample. So what are we looking at the bone marrow biopsy? We're looking at the cells in the bone marrow called blast. And you can see here, this diagram represents a formation of the blood from very early cells to more mature cells. So you can see these cells go from the stem cell level to the first recognizable cell in the formation is blast, and then they become mature and become red, whites, and platelet. And we hope these cells are what we see in the blood. The blast we can see in the bone marrow. So these are, we believe, we always explain that as a kindergarten phase of the cells, where these cells are clumsy, immature, and they cannot really perform function. It is normal to have blasts in the bone marrow, and it is normal to have 1 to 2% blasts in the bone marrow. However, we expect these blasts will evolve into normal cells and become a mature cells. But if they do not evolve into mature cells, that's where we worry about the fact that these cells are not maturing. And if we see a lot of these blasts in the bone marrow, that is unfortunately diagnostic of acute myeloid leukemia. When it comes to white blood cells, these are just certain terms that you may be dealing with. One is neutropenia. What is neutropenia? Neutropenia refers to the fact that there is different types of white blood cells. Neutrophil is foot soldiers against infection. And if we do see low neutrophils, those patients are at high risk of infections. If you can see here, as I reminded you that the blasts are normal to be seen and less than 5% blast is normal. But when we see those blasts to be above 20%, that's diagnostic of acute myeloid leukemia. In the past, that cutoff was more than 30%. And now there's debate about lowering that cutoff to 10% in certain patients who have certain genetic abnormalities. So there are situations where the blast is less than 20%, but because of certain genetic abnormalities and molecular mutations, we end up diagnosing acute myeloid leukemia. And it's in the interest of time, I will not go over all that detail. Genetics are key in terms of interpreting how bad is disease in acute myeloid leukemia. And this is just a 101 for genetics. And you can see the diagram of a cell. In the cell, there is a nucleus, and that harbors all the useful information about how a cell is supposed to function. And in that nucleus, there is these X-shaped structures called chromosomes. These X-shaped structures carry all the useful information how a cell has to perform its function, and it has genes and DNA. So these are three different terms that we frequently use in the context of acute myeloid leukemia. So I just wanted you to be aware about it: the chromosomes, the genes, and the DNA. So when we analyze the chromosomes, we can analyze the chromosomes with these X-shaped structures. And if we grow these cells and can analyze to see whether or not there is something wrong with these chromosomes, if it is missing a chromosome, that is helpful in terms of giving us very useful information about prognosis. And then we do more special testing, the PCR and NGS. We all have heard the word PCR in the context of COVID, where we were doing PCR tests to determine if somebody has the RNA of the COVID virus. But with the acute leukemia, we have over the years used this technique to determine if there is a permanent change in the genetic material of the cancer cells. And that just refers to mutations. So mutations refer to a permanent change in the genetic material of these cells. And these are just list of these different mutations that can occur in acute myeloid leukemia. Some of these mutations are more common. Most of these mutations are acquired. As I mentioned, there are hereditary mutations. So when we talk about mutations in context of acute leukemia, a lot of time we get a frequent question: are they born with this? Or was this present all along? And the answer is most of the time it's an acquired abnormality, not a hereditary abnormality. And you can see FLT3, NPM1. These are some of these mutations. There are 23 of these genes are frequently mutated. And the list of the genes that could be mutated could be 230 plus genes as have been identified to be mutated in acute myeloid leukemia. So what did these mutations help us? They help us in two use prognosis and target for therapy. So over the years, over the last many years, we have used it only for prognosis, and more recently, we've used now these abnormalities to target our treatments. So some of these mutations are just only once present in a patient. So some patients have more than one mutation, and here you can see this is a database from about 1,500 patients. You can see that some of these patients had 2 or 3 mutations, and that could make the targeted treatment somewhat challenging, and even make it sometimes the prognosis a little bit different and difficult, because there could be mutations that confer favorable prognosis. There could be mutations that could predict poor prognosis, could be present in the same patient. So in terms of the prognosis, we do rely on these mutations, and that's what your doctor may be telling you, that whether a disease is categorized in the favorable, intermediate, and adverse risk group. And to us as an oncologist, this is analogous to giving a stage of a cancer. You know, stage of the cancer predicts how bad diseases. A stage 4 cancer, lung cancer, what we are really hearing that, of course, is just it's bad, right? So we don't have the staging as such for leukemia, acute leukemia, but what we have is risk categorization. And we have identified certain abnormalities that are present at the time of diagnosis that predict for favorable, intermediate, or adverse risk group. And those help us decide what is the best treatment strategy for our patients. So these are some abnormalities here you can see have good response to chemotherapy, some have poor response to chemotherapy. So we think this information is quite useful also to predict response to chemotherapy. And you can see here, there is this group of patients called secondary acute myeloid leukemia. And that I wanted to give you an idea that not all of the patients who have acute myeloid leukemia start off as acute myeloid leukemia. Some patients have an underlying disorder such as myelodysplastic syndrome or had received chemotherapy, and that led to development of therapy-related acute myeloid leukemia. Those, unfortunately, historically has been associated with poor response to chemotherapy. Core binding factor, acute myeloid leukemia is a group of patients which usually respond very well to chemotherapy, and there's 2 abnormalities that are listed as core binding factor, 821 and inversion 16. They tend to respond very well to chemotherapy, and they are usually considered as favorable. However, there are certain risk factors that could potentially put these patients in high-risk group. So let's talk about treatment. The first phase of the treatment is induction. Induction goal is to get people in remission. Then there are patients who may not respond very well to induction chemotherapy, and they are considered primary induction failure. Patients who achieve remission, we decide what is the best post-remission therapy. Is it more chemo or transplant based on the risk assessment? If they are high-risk patient, we take them to transplant. If they are patients who are favorable risk category, they can get more chemo. However, that may be more relevant for younger patient population, but as I mentioned, we deal with acute myeloid leukemia in all age groups, including patients in their 60s, 70s, and that makes it a little bit more challenging. And we do try to use less intense strategies for managing those patients because of the comorbid conditions these older patients may have, and that makes it more challenging to treat older group of patients. So 7+3 is one of the old regimen that is being used. It is considered an intensive treatment, and that's was actually ironically developed in 1973 by these physicians. And we think that the remission rate from 7+3 is 60 to 75% for young patients. For older patients, the remission rates are lower. We tend to still use 7+3. However, some of the combinations have evolved, and 7+3 remains a backbone for some of these newer therapies, but it is still used for treatment of acute myeloid leukemia. And this is just a diagram of what is 7+3. You can see here is the green bar represents the 7-day, the cytarabine, continuous infusion of cytarabine, and the 3-day of daunorubicin, that what is constituted as 7+3 or 3+7. We do a bone marrow biopsy roughly 14 days from the initiation of therapy, and then determine if there is any persistent leukemia. If there is persistent leukemia, we consider additional treatment. If no persistent leukemia, we wait for recovery. And usually roughly between day 21 through day 28, after starting therapy, we start to see recovery of the blood counts. Meantime, we watch people for infection and make sure that they are eating well. However, we have made significant progress in terms of acute myeloid leukemia, and there has been 9 different drugs that have been approved for treatment of acute myeloid leukemia since 2017. And you can see some of these drugs, midostaurin or Rydapt, Idhifa, Tibsovo, Mylotarg, Zospata, Venclexta, Turismo. So these are some of and Onureg, those are some of the drugs that I'll go over quickly. So FLT3 mutation is one of the mutation that is present in patients with acute myeloid leukemia. It's one of the frequent mutation. And you can see on the diagram is the effect of this mutation as this protein that is present on the surface of the cancer cells, as a result of this mutation, becomes active. So it's kind of an ignition present on the cell that is left turned on. And as a result, the fact that this ignition is turned on, no longer the cell relies on a key to multiply. And as a result of this, the cells continue to multiply very, very rapidly. And that's could lead to development of acute leukemia. So we have developed FLT3 inhibitors to block the effect of this mutation. So one of the drug is called Rydapt. Rydapt is a FLT3 inhibitor. It's a multi-kinase inhibitor. It is believed to be a first-generation drug. There are newer generation FLT3 inhibitors have come up along. But patients who received in addition to chemotherapy and patients who received placebo, a significant improvement in the other drug is Myeloid, which is attached to an antibody. So to me, it seems more a special version of administering chemotherapy. And you can see the Y structure is an antibody. The blue dots are the chemotherapy drug. So the chemo is attached to an antibody. And then when antibody binds to the cancer cell, it injects the chemotherapy into the cell and cause the cell death. So instead of just chemotherapy circulating in the body and could be harmful for rest of the cells, this is a special way of administering chemotherapy. And here where they used this drug called Myeloid in addition to chemotherapy in patients who have favorable risk disease, there was an improvement in survival. And you can see here 77% versus 55%. So Myeloid is used in combination with chemotherapy. There is some risk of low liver toxicity with this agent, and there is risk of causing low platelet count. So we do watch for those side effects. The consolidation is another strategy after patients have achieved remission to maintain remission. And it is a backbone for a lot of chemotherapy that is administered. It's the high dose cytarabine. And there, as you can see on the picture, is the 6 doses of cytarabine that are spaced over 5 days. Most of the patients are hospitalized for this type of chemotherapy. These are patients who are in remission. They are getting this chemotherapy either as a definitive therapy or a bridge to a transplant. And there is risk of neurological toxicity with cerebellum, which is part of the brain that help us with the balance, can become abnormal as a result of this chemotherapy. The chance of that is very low, but there is risk for that. This is an agent that was recently approved, which is the Vyxeos, and it has a name or letter and name, so it's CPX351. But Vyxeos is frequently used. It's actually a purple color chemotherapy. It is considered intensive chemotherapy used frequently in treatment of secondary acute myeloid leukemia. Even though it is chemotherapy, it has less hair loss and mouth sores and less risk of stomach issues. However, being this is a chemotherapy, it does cause low blood count. And actually, in the clinical study where it was compared to 7+3, the counts were delayed by roughly 1 week. It does have anthracycline, and there is a lifetime dose limit of anthracycline. So so we have to be mindful when we have a patient who have received anthracycline in the past to give this chemo. This was the clinical trial where it was compared to 7+3, and you can see the survival graph. So this is the blue curve represents patients who received Vyxeos, as compared to the orange curve patients who received 7+3. And you can see there were more patients who were living longer with receiving Vyxeos as an initial therapy for secondary acute myeloid leukemia. So this does improve survival. And on the right is the graph of patients who underwent transplant with Vyxeos as initial therapy as compared to 7+3. And you can see the patients who had initial therapy with Vyxeos did actually also better after transplant as well. So to us, even though the transplant seems to be a useful strategy, here you can see the initial therapy also played a role in terms of post-transplant outcome. Not all of the patients are young and can able to get intensive chemotherapy. This is data from Medicare, where blue bar, part of the bar represents patients who are able to get chemotherapy or treatment, orange, no treatment. And that's, of course, older data, but roughly about 40 to 50% of patients in the United States were not healthy enough to get treatment. However, I'm hopeful that number is better now because treatment does improve survival. This is one of the drugs that has come up in treatment of acute myeloid leukemia who are ineligible to get intensive chemotherapy, and it's called Venclexta or venetoclax. It's a pill. And what it does is that it binds to a special type of protein in the body called BCL2 and causes activation of certain chemicals that allows the cancer cell death. So this is a pill that has been now added to low-intensity strategies called Vidasa and seems to have seen an improvement in the survival of patients who are ineligible to get intensive chemotherapy. Here, you can see the blue bar represents patients who receive Venclexta in combination with Vidasa. And as you can see, there were better survival. Remission rates were analogous to intensive chemotherapy. It worked for multiple types of acute myeloid leukemia. It does have low side effects, and there is about 20 to 30% risk of infection with this strategy. It works for different types of acute myeloid leukemia. It does work for the certain mutations more than others, and there is these IDH mutations where it does have a better outcome. The TP53 unfortunately does not respond very well. FLT3 mutation patients can respond as well with this strategy, but so it does work across different genetic subtypes and does not just have to be isolated to certain genetic mutations. More on Vidasa and Venclexta strategy. Sometimes we substitute Vidasa with Dacogen, especially if the patients have TP53. The chance to respond to this combination is usually after 1 to 2 months. Sometimes third drug has been added in clinical trials based on the mutation profile and has very encouraging preliminary results. With this strategy, the therapy has to be continuous. We cannot stop this therapy. So that is important to keep in mind. This is just a slide of a pathway that is active in the cells called IDH pathway. And I'm not going to go over this in detail, but this is a pathway where the cells all of a sudden are unable to mature. So we have learned about this pathway. And what we have learned is that when patients have these mutations in the IDH1 mutation or IDH2, it prevents the maturation of the cells and lead to immature blast. So we learned that that is one of the mechanisms by which acute myeloid leukemia occurs. So they use IDH inhibitors, and you can see what happened as a result of the IDH inhibitors. The cells subsequently can mature now, and it has become mature. So that's a useful way of treating acute leukemia, and that you're targeting the abnormality that leads to development of acute myeloid leukemia. So they used this drug called IDFA, and they showed that just using as a single agent, it improved survival. It had a chance of remission about 30%. It improved the production of the blood cells and was much less toxic than chemotherapy. It is very well tolerable. It has this complication called differentiation syndrome, where the cells, as they mature, they can cause fever, shortness of breath, and respiratory problems. It can occur in 15 to 20% of patients. There is a similar drug called livositinib or Tipsovo. Also, as a single agent, worked and achieved remission in 30% of patients and had a good toxicity profile. And again, unfortunately, it does cause differentiation syndrome too, which is again a condition where people can have shortness of breath, fever. And this was a study where Vidasa was added to the Tipsovo or to Tipsovo, yes, and the remission rates was about 50%. The differentiation syndrome reduced. So this was another strategy for patients who have IDH mutation, that a Tipsovo, which is a target against the IDH1, which targets the IDH1, was able to help patients who have this mutation. Zuspara is a gilteritinib, is a drug against against FLT3, and that targets the FLT3 mutation. And in this study, it was compared to intensive chemotherapy for patients who have disease has came back, and as a single agent was able to improve survival. So that's a useful strategy as well. Lastly, I'll go over maintenance therapy. The idea for maintenance therapy is suppression of leukemia cells after treatment so that the leukemia doesn't come back. And this is a drug called Onureg or oral azacitidine, where patients who had a disease was in remission and unable to go to transplant received this pill for indefinite period of time, and it did improve the survival rate, and the risk of leukemia coming back was reduced. So we do use this strategy for patients who have who are unable to go to transplant. So the idea of maintenance have gained traction in acute myeloid leukemia now. Onureg is approved, and there are other agents that are being evaluated. There are other drugs that could be sometimes used, but at least as a concept now, maintenance therapy is now being used more and more for treatment of acute myeloid leukemia. Lastly, I'll talk about stem cell transplant. And stem cell transplant requires people to undergo significant pre-testing, where we can identify if the patient is healthy enough to undergo transplant. It includes testings like EKG, echo, lung function test, dental exam, bone marrow biopsy to make sure disease is in remission, and blood test to make sure there's no infection going on. And usually for bone marrow transplant, that's the procedure. We take out stem cells from the donor, and you can see here that how painless procedure that is, that it does not require any type of surgery. The donors can be hooked to this machine called apheresis machine, where the stem cells are collected, and the patient then receive chemotherapy, and then they get the cells infused to their body. So I'll stop here and going to take questions that has been submitted. So
thank you so much, Dr. Fazal, for the presentation to get us started. Our first question would be, how does secondary AML differ from primary AML?
So, very important for us that we believe that there are patients whose disease has evolved from a prior bone marrow disorder, and the one which is pretty frequently can lead to evolution to acute myeloid leukemia is myelodysplastic syndrome. So that is, as a concept, is the one of the subtypes of secondary acute myeloid leukemia, meaning the patient may have an underlying bone marrow disorder, myelodysplastic syndrome, for years or months, and then it evolved into acute myeloid leukemia. Most of the time, we do our best to identify those disorders so that we can prevent evolution to acute myeloid leukemia. However, there are instances that we have not been able to identify, And in that context, sometimes patients get diagnosed with acute myeloid leukemia, and we look at their bone marrow results. And based on that information, we can actually also say that they may have had secondary acute myeloid leukemia. There is another category of secondary acute myeloid leukemia, as I pointed out, is a category which is related to chemotherapy or prior treatment. That is also considered secondary acute myeloid leukemia. Why is it important to know about this group of these patients? Because unfortunately, historically, those patients have poor prognosis. And so that's one important thing. Second thing is that more recently, we have treated these patients differently. And so making that distinction is important, especially if the patients are candidate for intensive chemotherapy. That drug called Vyxeos is used frequently in treatment of secondary acute myeloid leukemia. As I said, we have also used the Venclexta combination with the Vidasa for some of these patients. But usually, if these patients are candidate for bone marrow transplant, because of the poor prognosis associated with these patients, we would recommend taking them to transplant. For patients who are not, we continue therapy indefinitely to prolong remission as long as possible.
Thank you. Our next question is, after having a transplant for AML, is there a possibility of disease relapse? And if so, do we know why that happens?
So when we do bone marrow transplant, we are relying on two strategies. One is that the chemo that is given at the time of transplant will eradicate any disease that is present, number one. Number two, we are also leveraging the immune system of the donor to do the job, to make sure that the person's cancer cells never grow back. However, we can never be 100%, or we cannot guarantee that new immune cells in the patient body is going to kill any cancer cells that may grow back. And unfortunately, cancer cells can camouflage themselves from the immune cells and be able to grow back, because they can let the immune system to believe that they are normal cells and they can grow back. And that's unfortunately the reason that the leukemia comes back after the transplant. Why does it happen? Because of the quality of remissions going into the transplant, failure of the immune cells. And then unfortunately, there are instances where we have to suppress the immune system of the donor after the transplant because of graft versus host disease, which could also sometimes the treatment of graft versus host disease does not help either. So there's a wide variety of reasons that happen. And the odds of that happening, again, it depends upon the quality of remission, the intensity of the transplant, the type of leukemia. And we are hoping that like we have maintenance therapy for patients who are unable to go to transplant, we're hoping that we have a maintenance strategy for patients who go to transplant. And if they are doing well, that they are on this maintenance strategy so that the leukemia cells never are able to go back. And we, at this point in time, have different clinical trials which are looking into that, and we're hoping that this will become the future treatment. But of course, it has to be evaluated in the context of a clinical trial first.
Thank you, Dr. Fazal. This question is in regards to the risk stratifications. Is AML ever considered low risk?
So it's always, so I always talk with my patients that I also have a mixed feeling when I use the word favorable or unfavorable or intermediate. I think that the category, the favorable, is probably a little bit sometimes deceiving in the sense that that it is, that it is a favorable risk disease. I think even if you look at the statistics for favorable risk disease and the outcome with the intensive chemotherapy, and consolidation, the odds of staying in remission is roughly about 70 to 80%. That's the best number that we can quote in terms of the outcome of those patients. To me, that is still not really, as a patient, I cannot accept that number. I would want to hear 90% or a higher number. So to call a favorable risk disease as 70 to a category of a patient who has 70% odds of remission as a favorable risk disease is and to call it a low risk disease, I will have even more challenging time saying that. But I think that is sometimes that is how we differentiate between other subtypes of disease. So we have to come up with some way of communicating. But I think that I do not think of a acute myeloid leukemia as low risk, as unfortunately, as you can see, the statistics and the survivals we still have a long way to go in terms of management of acute myeloid leukemia. We have made improvements, but I think we're gonna, of course, still have way to go.
Thank you, Dr. Fazal. Our next question is, my spouse was diagnosed with MDS, considered high risk 7 months ago. They've now been classified as AML. If treatment lowers the blast, do they go back to being high risk MDS, or are they really AML with just a lower blast count? How does all of that work?
So, so the reality is that once it's evolved into acute myeloid leukemia, it is considered as acute myeloid leukemia. Theoretically speaking, how we sometimes describe to the patients, so for the sake of simplicity, sometimes we just talk about that type of language to be able to differentiate. But medically speaking, once it's acute myeloid leukemia, as the person mentioned, that it would be considered as AML with low blast percentage, not going back to MDS. But it is once it's acute myeloid leukemia. Now, there are times where patients have no evidence of acute myeloid leukemia to best of our technique. However, their blood counts are low and they kind of go back into not normal bone marrow, but a diseased bone marrow where the blood counts are low, but we don't find any evidence of acute myeloid leukemia. So there is, of course, gray area where there are situations where that analogy may be relevant. But reality is, once it's acute myeloid leukemia, it should be considered as acute myeloid leukemia and managed as an acute myeloid leukemia in that context, because if it is a secondary acute myeloid leukemia, because those patients at high risk of disease coming back should be considered as high risk disease and should be managed like that.
Thank you. And there was a part 2 to that question. And is there a difference between treating AML that arises from MDS than just treating AML? Are there differences in the way you approach treating the disease?
So absolutely. So I think that as from the prognosis point of view, absolutely a huge difference in terms of the outcome. We looked at the study where the 7+3 was compared to Vyxeos, and 7+3 does usually very well for de novo acute myeloid leukemia, but when in that study, it didn't really do very well for the secondary acute myeloid leukemia from an MDS, and Vyxeos was better. So that was a group of patients that benefited from a different strategy than the 7+3. In terms of the other options, we have used Vidasa, Venclexta, Dacuzum, Venclexta for some of these patients who are not eligible for intensive chemotherapy. That would be another way of managing these patients. But the reality is that this represents a high risk group of patients, not just because of the prior MDS, but also the fact that the genetic abnormalities that occur in this group of patients tend to be more difficult ones, tend to be associated with poor prognosis. So So again, if the patients are eligible for transplant, we take this group of patients to bone marrow transplant because we're worried about the risk of relapse is going to be always very high. So so that's the other aspect of this problem.
Thank you, Dr. Fazal. Our next question is IDH in only AML, or is it also in MDS?
Yeah, so so IDH mutation has been identified both in the MDS, acute myeloid leukemia, and in other group of blood cancers, and even in non-blood cancer for the sake of discussion. But so IDH mutation is not just relevant only. However, the drugs that I mentioned, the Tibsovo and the IDFA, at this point in time are approved for treatment of acute myeloid leukemia, but they have, I mean, there is clinical data that has there is clinical data where these drugs were used for myelodysplastic syndrome with good outcome as well. So some of the trials allowed patients with myelodysplastic syndrome and IDH mutations to be treated with these drugs. So I think that is that could be seen, and sometimes we have used those drugs from acute myeloid leukemia into those situations based on the unmet need if we had no other option available.
Thank you. Our next question is, what is the survival rate after MDS when it transitions to AML?
So, I mean, it's a very, you know, when we talk about MDS to acute myeloid leukemia, as I mentioned, we put these group of patients as high risk or unfavorable risk category. For unfavorable risk category, you know, depends upon what option is available for the patient. If a patient can go to a transplant, their survival would be completely different than a person who's just on treatment with Vidasa and Venclexta. So I think that the survival is very relevant in terms of what drugs they have used prior to evolution to acute myeloid leukemia. Just to muddy the water, a patient who has acute myeloid leukemia developed after a long treatment for MDS is different. So meaning that there is a patient X who got treatment for MDS for years and then evolved into acute myeloid leukemia versus a patient that we believe has secondary acute myeloid leukemia but never got treatment for MDS. That's a completely different group of patients. So it's a very, you know, heterogeneous. Overall, as I said, unfortunately, it is a high risk of group, a high risk patient population, but it depends upon those variables, honestly, and what strategy we offer. We have patients, and you can see the Vixios study. Those are all secondary acute myeloid leukemia, where you're seeing, you know, long-term survival for these patients who got transplant. So it's like I said, it depends. So here you can see that this is secondary acute myeloid leukemia who got successful treatment with Vyxeos. So, you know, 40% at, you know, 1 year with the Vyxeos and stem cell transplant. I mean, it's, and then for patients who just got transplant, you can see it was about, you know, what, 65%. So again, it depends upon, now if you look at the Vidasa and Venclexta study, secondary acute myeloid leukemia could have, you know, 12 months survival. So it depends upon what strategy was given, what options were offered to the patient, how well they responded. So.
Thank you. Dr. Fazal, for a newly diagnosed AML patient, are there some questions that you would suggest that a newly diagnosed patient should make sure that they ask about when they're meeting with their treatment team?
Yeah, so I think that it's very relevant from the beginning to talk about the fact that what is, and I as a clinician, and over the years, this is the first thing I ask, when the patient is diagnosed with acute myeloid leukemia, the question is that what is the goals of treatment? Are we going to take this patient to a bone marrow transplant and cure the patient, or are we going to take a less aggressive route? And here it's very important to have that discussion with the physician and with that what are the goals of care? I mean, there could be a person who's really looking at certain things that they want to do. They cannot, let's say, bone marrow transplant requires a lot of frequent follow-ups. There could be a situation that a person doesn't have a caregiver, and they're looking at oral options. And so those things have to be discussed, that what are our goals of care here, but what is the goal? So I think that type of discussion could help the physician discuss what would be relevant options for the patient. There are some patients who want to be aggressive from the beginning. There are other patients, they want to take a less aggressive route initially and then see how that goes. But those goals are relevant in terms of what is the ultimate goal. And if the ultimate goal is to maintain quality of life, that's can happen with the options we have now available for some of these treatments. So that is, I think, is the key aspect. How do we then of course the rest of the details in terms of what is my prognosis in terms of a favorable, intermediate, or unfavorable? What are the odds of remission with different strategies? And so then it becomes relevant in terms of what path a person takes to the ultimate goal. If a person wants to go to transplant, as I said, for that person, they sometimes are given intensive therapy. Some people can still go to transplant with less intense therapy. So those then the fine details about what is the first step is sometimes becomes then relevant in terms of what is the ultimate option. I think in terms of the other questions, really it's about important is that are there any clinical trials I think the clinical trials are really always very helpful. We have made all these advancements, and thanks to all of the patients who took the option of going into the clinical trial. We would not be discussing all this progress without the help of those patients that took the extra step, decided they are going to go on to a clinical trial. I mean, imagine that they had to make that decision and they really were thinking, okay, we're going to do, and yes, they could be randomized to receive this or this, but they just took that extra step. And that is very thankful to all those patients who did that, because it was not easy for them, because with all the resources that we have limited, I think we're in depth for their the contribution to this field. By going on to the clinical trial, we're able to now help more and more patients. So I think the clinical trial, if there is an option of clinical trial, go with that. We have right now, at least at West Penn, I have for patients who are induction ineligible trial for acute myeloid leukemia, who are either able to get Vidasa plus Venclexta versus Vidasa plus Venclexta plus magrolimab, which is a enhanced trial, which is we're enrolling patients for that. So, I mean, these are things that we hope that at some, future date, we are able to share with you the results of that, and these drugs hopefully can make a difference in terms of that. So if there is a clinical trial for at your center, I would say that go ahead with the clinical trial, because that's how we have developed all these drugs. So I think those are the two important things, is that, what are the goals of the care, and then if there's clinical trials. So those are, I'll just keep it simple and just highlight those are the most important thing to me.
Thank you, Dr. Fazal, and thank you for bringing up about clinical trials. So that was another question. So should patients be discussing with their physicians the clinical trial options that are available at the time of diagnosis? And that doesn't mean if you enroll in a clinical trial that that's your last option. Sometimes there's a myth that clinical trials are the last option for patients. And would you like to talk a little bit about that? And should patients be asking about clinical trials at the time of diagnosis?
Absolutely. It is very important to ask from the beginning. And I think that's where it's, and you're absolutely right that that the notion about the clinical trial is it's a last resort when we don't have any options left. I had recently a patient whose spouse passed away from some other cancer, and eventually went on to the clinical trial. And his first the point that he came to talk with me about, that was for that disease. His first thing was that, if my spouse is alive today and we would have to do it all over again, their first thing would be to go to the clinical trial from day one. And that's where what some of the people who have gone through the cancer is there. That's what their own words are. What I would say is that yes. So as you pointed out, and what we in oncology, how we have developed these options is that we first, of course, offer to the patients who don't have any, if a drug X comes in, it's first tried in patients who have no other options. And then, of course, it moves up in the front. And as I said, I give you the example of the magrolimab. Magrolimab has seen some promising results with combination of Vidasa and Venclexta in single arm studies. However, it has to be, for it to be the new standard of care, has to be treat and become a standard for a newly diagnosed acute myeloid leukemia. It has to be given to a new patient. And yes, those patients may not be able to know whether they are getting placebo or the active drug, but that's how we will know. I mean, there are things that we've learned from clinical trial over the years where a certain drug worked or not worked and has to be evaluated in the context of randomized setting. And I think, your organization and all the organizations that have this information, I get all these feeds in my browsers about all the clinical trial that you guys, the Aplastic Anemia MDS Foundation highlights in the area which were to help enrollment. I think it's remarkable, all the help and to educate the patients and the providers about all the clinical trials that are available. It's, as I said, that's the only reason we have 7 new drugs available is through the results of the clinical trials. And otherwise it would be, we're doing the same, what we have done for 50 plus years. So
thank you so much, Dr. Fazal, for sharing your time and your expertise with all of us today and answering all of these wonderful questions from our patients and families. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send us an email to help@aamds.org. Give us a call at 800-747-2820, or you can submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our program. Thank you again, Dr. Fazal.
thank you.